Greetings. I'm Jennifer Potter, Associate Professor of Medicine at Harvard Medical School and Director of the Women's Health Center at Beth Israel Deaconess Medical Center and Director of the Women's Health Program at Fenway Health. It's a pleasure to introduce our panel for today. Thank you for joining us. I'd like to introduce first Dr. Scott Leibowitz, Head Child and Adolescent Psychiatrist in the Gender and Sex Development Program at the Anne and Robert H. Lurie Children's Hospital of Chicago, and Assistant Professor of Psychiatry and Behavioral Sciences, Northwestern University Feinberg School of Medicine. To his left, Dr. Catherine Barretts-Dalk, Chief Resident, Department of Psychiatry, Hospital of the University of Pennsylvania. And next, Dr. David Malbranche, Primary Care Physician, University of Pennsylvania Student Health Services. To his left, Dr. Melanie Davis, President of Honest Exchange. And then Dr. Jason S. Schneider, Associate Professor, Division of General Medicine and Geriatrics, Emory University School of Medicine. And Dr. Carrie Roth-Baer, Associate Professor in the Departments of Community Health and Preventative Medicine and Medical Education at Morehouse School of Medicine and Associate Director of Educational Leadership for the Satcher Health Leadership Institute. Let's think a little bit about working with trainees and helping people learn how to communicate in totally different ways, perhaps from what they grew up with and are familiar with. First, how can we help our trainees understand the importance of this and understand what the impact of not doing it might be with a patient?
I come at it from a wellness model. In medicine, we're trained to diagnose disease and treat it. And so I emphasize the importance of sex and sexuality in contributing to the overall health and wellness of a person. And so by proactively addressing those issues with people, you are supporting their whole person and helping them really actualize their health.
I think practice, practice, practice. So we can't just give a session or a lecture at one point in the medical school experience and expect that people are going to be comfortable. They may not have explored these areas within themselves, and now we're asking them to explore these areas with patients. And so to allow that time for their own values reflection, to get comfortable with what language, what behaviors, how to understand, how the body works from not only kind of the sexual function aspect, but the relational aspect, and again, how those things may or may not go hand in hand. But to really give that time for practicing, talking not only in the standardized patient setting, but with other patients, within their attending settings and clinical settings, to really get to practice and be in those spaces like you were talking about, where you may have used language that didn't work, but to have the opportunity to say, hey, I'm sorry, thanks for correcting me, and get to practice that.
Yeah, I think on an institutional level, the only program that I've been involved in the past was one at UMDNJ, where they actually had a whole sex week. And they actually went into biological issues with intersex issues with patients, trans issues, other kinds of issues with gender identity, and then sexual health in general. And it was mandatory for the second-year medical students to go through that week, or else they couldn't move forward in their clinical rotations. So they were actually forced to go. And I've rarely seen a program like that, and it had both the medical school support, like the higher university support, everything like that. But I think one of the things that Carrie's saying is a very interesting thing, in that I think it has to be integrated into the whole curriculum as part of the, so whenever we're doing these patient models, a lot of people may do problem-based learning, where you have a case of a patient and you use that to teach about the renal system or the cardiovascular system. And then this also can be a component of it. Like in your standardized patients, when you have role play or anything like that, have one patient that's has issues of gender identity that aren't the typical ones that they're going to see every day or aren't heteronormative, so that becomes part of the integrated teaching experience. I think having that like practiced or repeated over and over again, instead of maybe just having it set in a week kind of separate from everything else, because the reality is when they go out into the real world, it's not going to be segregated or compartmentalized into 1 week, like, oh, this week I'm seeing all my trans patients or gender nonconforming patients. It's going to be every week as it goes along, they're going to be sprinkled in your practice, and they're going to be sprinkled and admitted to your hospital. so you're going to have to deal with them. So to try to replicate that early in their training, I think is a reasonable thing to attempt to do.
I think it's also important to show students what types of errors can be made, and not just focusing on the verbal errors, but the nonverbal errors as well, and processing those types of nonverbal cues and how people may express discomfort with issues they're not necessarily thinking about day to day, in order to help them understand, oh yeah, that's how I look or come off in front of that patient when they say such and such. And I think that that's a really, really important way to help people, whether it be in small group discussion or various seminars that you can do where they're interactive with faculty members and students, to help them really move forward in realizing what it is about them and their comfort level that may impact some nonverbal messages that they may be sending to the patient.
To that point, I was observing some medical students at Sex Week, actually. They were working with standardized patients, and one of the medical students said, "So you're not having high-risk sex, are you?" And it was such a perfect example of, A, what not to say, and not how, you don't phrase a question that way, and B, if you're automatically shaking your head and crossing your arms, of course you're not going to get a truthful answer.
I think it speaks to an important point, which is that often when students are in the process of learning, they're sort of learning what the buzzwords are. And they see a man who has sex with a man and part of the question stem, and they're looking for some sort of STI screening in the multiple choice answer. And I think we need to make sure as educators that we're stepping away from sort of saying, here's the behavior, here's what you need to look for, which is certainly part of health and wellness, and really present this as an opportunity to build wellness promoting relationships with patients, to build rapport with patients, and just sort of taking a step back from this is the clinical information that you must master in order to graduate.
These examples are incredibly compelling in terms of trying to convince a trainee how important it is to be sensitive. But I think that we all have had instances of realizing that some people come to sensitivity very naturally and easily, and for other people it's more of a challenge. And I'm wondering if any of you have had experiences working with people who need a little bit of extra help, and what kind of help brought people along in this regard.
I think encouraging them to make questions about sexual health routine, just like questions on review of systems about chest pain or shortness of breath. So if you make it a normal line of questioning that you ask every patient on a routine basis, then it becomes easier to overcome the barriers you may have as a trainee to getting at these topics.
I think it's also creating safe spaces. It's safe spaces to have conversations. It's safe spaces to make those mistakes. And I know in teaching med students, I've had some who struggle with language and say something that is perceived as very offensive to some in the room. And how you acknowledge that and then let them have that conversation amongst themselves, but also be there to help, kind of bring things back on track, but to talk about those differences and allow people, sometimes that most powerful learning happens peer-to-peer, not necessarily kind of from the top down. And so sometimes it's also that patient telling you that, the language doesn't work.
Faculty can be helpful in role modeling it too for learners who are struggling with these skills. Go into the exam room or at the bedside and demonstrate how you do it yourself.
And not call them out, like kind of, it can be a very judgmental and embarrassing thing for them. And as much as like a trainee who makes a misstep as far as that's concerning sensitivity with LGBTQ populations, they could also feel very judged and put off, because it could be based on their religious beliefs or their level of experience or inexperience with diverse populations. And if you either call them out in front of the patient or you scold them for it, it's going to push them more in a corner. And I think one of the other components of that is to have them actually get back up on the horse, so to speak, and try it again. So say, look, bring them to the side and say, look, there's a different way you could have handled this. So I'm gonna show you how, maybe through role modeling, maybe through just telling them or instructing them. And then the next time they see a patient, sit in there with them and say, we're gonna have you try this again and see how you think. And then, you foster some trust and some confidence in them that they can actually move past that. And I think having that practical experience will help them push past that.
think it's also important to encourage people to get out and socialize with people who may be different from themselves. So if I identify as a lesbian, that doesn't mean that I'm cool with everybody who's not heterosexual, or, you know, I mean, people in general need to get out of their shells and meet other types of people, because the more we integrate with each other, the more comfortable we are using the language, becoming familiar with what's offensive and what's not offensive. Another one, if people can, if faculty at least can take what's called a SAR, a sexual attitude reassessment. It's usually a weekend program where people watch videos, process them, have discussions, and have a lot of time for reflecting on their attitudes and assumptions about people of different kinds of sexual identities and people who have different interests in terms of sexual behaviors. And that's just a way that it can kind of rattle your cage a little in terms of testing what your comfort zones are. But that means if you have a student or a patient come to you who is talking about these things, you're not going to freak out because you have at least a baseline knowledge of these identities and these behaviors.
I'd like to close the panel with a discussion about aha moments that administrators or clinicians or trainees may have had in learning this material, and moments that really show the importance of these sensitive communications for the patient. If you can think of any stories that get at those things, I'd love to hear them.
So I'll tell you an aha moment with a student was she had never been asked what she preferred to be called. And it was a part of my normal language. I'm the faculty advisor for our Alliance group. And I just said to her in an email, you know, what do you prefer to be called? And she came up to me after her and she said, I'm so thankful that you asked me that. Nobody's ever asked me that. And I used her terms, I used her pronouns, but it was very kind of liberating. And it also, in a very subtle way, kind of showed this safe space. It showed that this is a place where we can have conversations. It really opened a door. And for me, it was something that I felt like was very small and mundane, but clearly it had an effect for this person.
I had a student who said he was a senior in college, and I was the first professor he had ever disclosed that he was transgender. And I thought, wow, you know, that was such an honor for me to feel that he trusted me enough. But when I asked why, it wasn't because I was just a nice person. It was because all through the semester I had been talking about transgender issues and incorporating it through different themes, not just in the gender week that we were talking about that, but when we talked about relationships. So that idea of moving it across the curriculum and using the terminologies and the references and the case studies and the standardized patients is so important, because we never know who that's going to resonate with.
People are watching and listening all the time. And so it may not be in a one-on-one clinical encounter. It may be just that you're doing your day-to-day activity. When people see you interacting and treating people the same way, regardless of their race, gender, sexual orientation, whatever different social demographic thing you can think of, people are paying attention, especially students pay particular attention to how you behave. And so you can tell them one thing till the break of dawn, but if you're not actually practicing that and they don't see you acting like that every day, it'll make more of an impact on them. So that's a great story to hear, because it sounds like he was paying attention very intently.
When I was a student, right before we started our clinical rotations, the LGBT medical students group put together a panel, and they spoke to our class about being LGBT identified medical students in the clinics. And it was this, I think for a lot of us, it was this moment of, well, if the people who are providing care feel uncomfortable in these little ways, in the ways in which their supervising physicians or nurses are talking to them, what must it feel like for the patients? And so I think part of it is making sure that we are also promoting a culture of openness and role modeling amongst ourselves as educators, because that's a really powerful teaching opportunity for people.
So I work with an assistant who does my scheduling, and she handles prescription requests and refills, and she covers a lot of doctors in the department and in the practice. And when we first met each other, and I explained to her that many of my patients are actually going to have a difference in what the medical record indicates and how they identify, she looked at me and she said, okay, tell me more about it. So I explained to her the difference between some of the basic terms. The next day I came into work, and on her computer screen, there was a little yellow memo that basically just said, sex is body, gender is mind, with a happy face on it.
That's great.
And then, you know, in every patient encounter I have since who call her to schedule, they don't just come in and say to me, you know, doc, thank you for getting it. They actually say, you know, your assistant gets us too. And so it's not just about me, it's about an entire system. You do not have to be a professional with a degree, the MD behind your name, to understand these issues and to make people feel welcome. And so that aha moment, I took a picture of that memo and I use it in my presentations because I think it just shows everybody can really understand ways to improve a welcoming climate for all patients.
Thank you very much. I think that's a wonderful place to stop. And thank you so much for joining today.
Thank you.